Thanks, Elena. It's a great pleasure. Thank you. I really enjoy being still connected with this community and having the opportunity to speak, especially after Bill. It was very gracious of you to suggest that I come after him. Thank you. And I think the last time I presented, it was in person before the pandemic, and I shared quite a bit of the community-based work that we do at the studio. So I'm going to show some of the actual results from that work. So we're kind of at the end of those projects. And I really wanted the opportunity to sort of bring a few projects together. And so I'm going to cover 3 different projects together today. And all of them have a connectivity around really low tech, like super low tech innovation. And I'm going to explain why they ended up that way and sort of the landscape of healthcare and why in healthcare, when we do design, we're really looking for impact. We really want something that's actually going to spread and be adopted. And so as you'll see, as I explain these projects, the kind of circumstances of the sector and the kinds of topics that we're taking on in these projects at the studio really just develop into extremely low-tech solutions. So I'm going to cover 3 different projects today. One is a patient communication tool that I developed with St. Mike's Emergency Department. The second one is a project that I did during the pandemic, which was a result. It kind of came out of the emergency department work, but it sort of just took on a life of its own during the pandemic. And then the third one is a project I think I spoke to last time I was at TorCHI, which was the Sooner project, which was about addressing the overdose crisis. So all of this work is happening at something called the Health Design Studio at OCAD, which I founded in 2017 when I got my Canada Research Chair in Health Design. And we do a whole bunch of different kinds of projects, but most of them are very community-based, public health orientation, emergency medicine orientation as well. And we use a whole bunch of different design approaches. So they're not necessarily UX projects. So I kind of give that caveat. Hi, Deb. Nice to see you. But I think it's pretty interesting that this is where we are in doing this kind of work. So I'm going to talk about low tech for high complexity. The healthcare sector, especially in clinical environments, is really highly complex. There is a lot of high tech. There is a lot of UX work. There is a lot of interactive tools that are in these spaces that are part of the workflows of a lot of clinical environments. And when we come in to do design work in those environments, we encounter a lot of constraints to design. So we can design something, in theory, we can design something in a sort of as an exploration, if you like, but to actually get it into implementation, we encounter a lot of constraints. A lot of that has to do with resourcing, so the workflow itself, so the actual context of clinical work. In the case of the emergency department, that means, super high patient volumes, a staff that is rotating, maybe losses in staff, especially nursing staff, a lot of different complex cases coming in and out, especially in St. Mike's, which is a downtown sort of urban emergency department, a little bit different from some other contexts in the kind of patient mix that they have. But anything that we're introducing into the clinical environment has to really fit with the situation. And that usually means something that's very discrete, very ultra brief, something that can fit into an already very overburdened workflow. So the other thing to consider when we're looking at particularly UX projects or any kind of digital tool is that the digital landscape in health has 2 very disparate characteristics. On the one hand, we have this high-tech possibilities and lots of high-tech equipment and so on, and a commercial marketplace around that is very specific. And on the other hand, we have this kind of sort of consumer side or patient side, patient family caregiver side, which is often really challenged in terms of digital literacy, digital access, issues of low literacy in the case of downtown Toronto. And those two things together actually make it really very challenging to put anything actually into production, right? So again, we can create things in theory, but actually getting them into adoption is another question. So what we've tried to do in these projects is look for channels where we can create spread and adoption outside of the actual project itself, so that there's a life for the work beyond the research projects. What that means is that we're doing sort of a patchwork of connectivity, if you like, and that can be extremely low tech. Part of the sector characteristics is the sort of landscape in terms of who's actually supplying digital tools to the marketplace. And you can see from this chart that there are some really big players, Epic being the biggest. Then we have Cerner and Meditech. And then there are a few smaller suppliers of some of the biggest pieces of software. So for those of you who are not familiar with issues of interoperability and the marketplace for things like electronic health records, there are these 5 big players. There's really only 3, actually. And they're not interoperable. So, ideas about sharing patient information between a family doctor and an emergency physician, or even transferring information from the family doctor to a pharmacist, or from the emergency department to a caregiver, is not a straightforward thing to try to do. The companies that are in the space really have locked down the ability to add on tools and create connectivity that would allow for sort of bespoke tools to be created, and sort of create more of a flourishing innovation ecosystem with digital health. So that's the kind of the hospital side, or the clinic side, is really constrained by these big players. And that makes it very, very difficult for researchers or HCI researchers to take something from studio or lab and into the marketplace. It makes it very difficult to do adoption. On the other side, we have the app landscape. And I'm sorry for the fidelity of this image. These are the top 10 apps in Canada currently, if in the Google Play Store. There are many others, but these are the top ones. And while there's a lot of opportunity for mobile apps to play a big role in the sort of landscape of clinical care and the landscape of patient caregiver management of health and wellness, we are currently seeing what could be described as a sort of a separation, or a kind of an issue around access and inclusivity in these apps. So, one of the top apps available is My Health Record. My Health Record is an attempt for hospitals and other larger groups to provide access to their patients, to their test results, imaging, and also sort of connect them with their appointment and everything, sort of like a one-stop shop. But it actually really assumes a level of digital literacy that is above the average. And it assumes also the computing power on the phone that is not universal. So it's also not necessarily an app that can speak across platforms. So if you've ever tried to do this, and this happened to me recently, Ilona was asking me, can you relate your experience in the emergency department? I had an accident that put me in the emergency department, and I had to get some imaging done. I got some initial x-rays. Those x-rays are not available to my family physician or my physiotherapist or anybody else in the network of care. So, as most people experience, there's this discontinuity in the care experience. So while we have these apps, and we've had medical related apps for a long time, we're still not able to really complete the pathway for people. We're not able to complete for the communication or information transfer pathway, and we're not able to do sort of basic functions for people across the board. So I'm going to talk first about co-designing discharge communication after emergency care. This was the project in St. Mike's that I mentioned, the first one. In this case, what we were asked to come in to develop a tool to support communication at the end of an emergency department visit. So these are patients who come into the emergency department. They're not sick enough to go into the hospital. They get discharged at a point later with usually instructions for follow-up care. So that might be going to access a family physician, or perhaps it's a specialist. They might also have additional needs that are more social related, so housing or social care related needs like caregiving support and those types of things. So currently, and I experienced this when I went into the emergency department myself. Currently, mostly what happens is somebody goes through the process of being seen by emergency physician. They come out the other end of that. They're still probably a little bit in shock or in pain or uncomfortable, usually. So they're not in the best place to actually receive instructions. And usually you're given verbal instructions. And so if you've come in with somebody else, they might be able to help you a little bit by being a second pair of eyes or a second pair of ears on the conversation. But you might come away from that interaction with the emergency physician, typically it's the emergency physician, and then you're kind of a little bit not quite sure what to do next. And that's actually super common. And unfortunately, you can imagine that leads to all kinds of issues: missed appointments, missed follow-ups, taking medications not in the right way. It's a really simple thing on the surface that we should be able to fix. Oh, excuse me. And so what we were trying to do was understand, how can we intervene in this situation? How can we create a tool that's going to work for the context of St. Mike's and hopefully other urban emergency departments? So that means it needs to work for a range of literacy levels. It needs to work for a range of language competencies. So English is a second language for the majority of patients that come in through the emergency department at St. Mike's at the moment. We can't assume high literacy levels or English as a first language. So those are kind of some initial starting points. And as you can see in this picture here, this is me in the studio, and my team is around. And we did, the classic kind of contextual inquiry that you might do at the beginning of an HCI project, where we're going into the environment, we're doing observations, we're collecting artifacts. So you can see on the board there all these different potential tools, existing tools that were tried and didn't get adoption, ideas from all kinds of other places, sort of little small, perhaps windows into workarounds that people have, like voice recording something and then sending it on their phone to a patient. There's lots of little things that people are doing to try to get around these issues, but none of them are actually really kind of put together in any kind of coherent way. And so we, start off the process by doing this kind of mapping observation, mapping all the workarounds and all of the different insights, not just from St. Mike's, but other emergency departments, other emergency physicians, nursing staff, and so on. And then we got into, how can we solve for this? And we quickly discovered that really the environment in which a tool can live is actually on the physician themselves. That's actually the landscape we have to work with, because the physician is moving around constantly. So we're not really being able to develop something for a screen, because the emergency physician is not next to a screen. There's no screen in the consult room. Typically, discharges can happen anywhere in the emergency department, including the waiting area, up at the nursing station, standing at the exit door. So there's not really a stable place to use any of the usual types of technologies. Really, the only stable place is the physician themselves, and in fact, the physician's pocket, because they need to be able to carry this thing around with them somehow, or access it really easily. So we're not just looking at, maybe the screen itself, or an iPhone, or an Android phone as the vehicle for delivering the tool. We're looking at the landscape of the whole environment, and particularly the physicians themselves and what they might be able to interact with. So we had to come up with something that was like really nimble. So at this point, we knew that the Epic system was coming down upon the environment of the hospital at some point, because there was a contract signed and millions of dollars were being put into place to make this implementation. So what we decided to do was to create a solution that assumed digital connectivity initially. So we weren't ruling out digital options, but recognizing that the connectivity to the EHR system itself was probably very unlikely. Okay, so that's actually the reality. But we wanted to provide our stakeholders with a pathway to potentially implement eventually, if they had the opportunity to add this tool to their electronic health record system, that they might be able to do that in the future. So keep that in mind when you kind of see what I'm going to present. So in part of the process, I described the contextual inquiry. The next step is the sort of prototyping phase. We did a lot of field testing. We did a very transparent design process. If you kind of maybe come back here, we actually had COVID sort of landed right in the middle of our project. So we ended up creating a lot of transparency through digital sharing documents, prototyping digitally, using Miraboard to share with our participants. So we really ended up with a very co-creative process, I would say, with a greater amount of sort of power sharing and decision making that was shared decision making among the team. So really, we weren't kind of working as a design team separately from our collaborators. We were really working together. We ended up with lots of different versions of what could be a tool. We were working with some concepts that had been brought to us about reassuring communication. So kind of a model for a framework for actually having the conversation with patients. So that piece had already been done. And our job was to kind of interpret that in a way that would work in the environment. We had in situ testing. We had 4 co-design sessions. We had a range of different people in those co-design sessions. What we had envisaged before as being these big co-design events ended up being lots of smaller, discrete things cobbled together during the pandemic as best we could. But actually the result, I think, was really positive, because that meant more continuous involvement. We used the prototypes with 57 different patient scenarios. So that means our tool was taken into the emergency department and used by a range of emergency physicians with 57 different patients. So they kind of trialed it in real time. And that really allowed us to refine it quite well. So what we ended up with was actually a sheet. A 1-page piece of paper that could be printed with no need for like color or special paper or even special sizing. It could be a kind of one-time print. You could print a bunch at the beginning of your shift, and then you could just take them from the top of a pile and fill them in with the patient and give them to them. And over the course of the project, we really focused in on the information design to really get to the language that was going to be appropriate and the structuring of the sheet to match the clinical workflow. So in that conversation that the emergency physician is having with the patient before they discharge, there's a really strong kind of process to it. So what we did to you, what was significant about what we did to you in the emergency department. So like what tests we did, what those tests showed, what our assessment is, or like the prognosis, who to follow up with, how to follow up with that person or that group, the clinical team, and then what you can do to feel better. And that includes things that you should definitely come back if these things happen. So it's actually super simplified. It appears to be not a particularly sophisticated tool, but there was a lot of work that went into this to make it kind of an elegant information design. And you can see a few quotes there from different participants. So this was actually, a really nice segue into what happened next, which was that we're not really assuming any sophisticated interaction. We're not assuming high digital literacy. We're assuming low literacy, takeaway, simple, very speedy, lightweight kind of tool that can be implemented in real time. The work from that project then flowed into something called COVID printables. This arose out of the work that the same group actually, so the emergency physicians we were working with said, hey, we have nothing to give people. The public health guidance is 3 pages long, it's dense text, there's no imagery, we can't give this to people. Not only that, but we actually can't print it because we don't have staples. Yeah. Sort of basic technology barriers to being able to do, things that we might take for granted in a lot of other sectors. So we ended up creating COVID printables initially for the case where somebody comes to the emergency department with symptoms of COVID. We created it knowing from our previous work that it had to be super low literacy. It had to be potentially understandable with no literacy. And that it would be something that would be easily adoptable. So we had to create something also that worked with evidence guidelines, that complied to evidence guidelines, that was readily updatable, and that it was shareable. So we actually are pretty proud of this project. We won several awards for the work. We presented to the Privy Council of Canada the work that we had done and how much it had spread. And what started out as a project that was really geared to, helping out our colleagues in one emergency department ended up being a project about refugee and community health, because it got picked up by the refugee community, public community health community sort of worldwide, and really spread just incredibly quickly. So here were some of the kind of highlights of how this worked. We created these 1-pagers. We followed the same kind of super low-tech principles that we developed for the patient communication tool at St. Mike's. And we created these super low literacy 1-pagers that could be printed easily, that relied on sort of pictograms to indicate guidance, that had, a structure to them that was the kind of the social motivator. So we always had a social motivator statement at the top, whether that was taking care of self or taking care of others. And then we had similar structure to the patient communication tool, what the current guidance is, how to take care of yourself, and what to do to follow up. So very sort of basic, simple structure. We had a very positive language frame. So we used positive language around guidance. So there was no kind of negative, no use of no use of don't. We removed all of that language, so it was all geared towards a positive message of what was possible to do. And these tools were done collaboratively, all online. So we had an open kind of innovation approach to the work, where we had continuous improvement, an open weekly working session, where we had a range of different people involved: physicians, social workers, family medicine people, public health people, people from sort of epidemiology, graphic design, information design. And then together we created these tools, and then we kind of put them out there into the world. And we worked with a couple of different community health groups to test them formally, because we did actually want to make sure that the pictograms that we created were understandable. And that we hadn't, made any, that this wasn't going to actually result in a poor outcome for anybody. So that's super important. And we also wanted to do the testing to make sure that we could tell the public health and the health community that we had gone through these rigorous steps of development. Because one of the key things, of course, in health is that you need an evidence base really to back up your work. So that was a key piece of it too. And then we created certain areas of the sheets that were editable, so that, if you were a clinic that needed to brand your public health communication so that people felt they could rely on it, like it was actually real and could be trusted, that people could do that. So we deliberately created elements to the tool that were customizable to suit that need, not just for a sort of, known groups, but also so that it could be more easily spread. So you can see this is a short version, or I guess more extensive version of the steps that we went through. We did this for multiple sheets. We have 11 sheets in total. About 4 of the sheets were super well used. Some of them really weren't used much at all. One of the biggest sort of uptake was on a sheet of how to keep yourself safe in apartment living, because that wasn't something that was being covered by public health. And what you can see here is a sheet that was posted up on the inside window of COSTI, which is a refugee group, not-for-profit, that operates within Toronto. They work with some of the most vulnerable refugees, and so they were using the tools not only to provide it to their group of community health workers, but also as materials that they could actually post up. So when people came to them physically, they could see something. So, one of the things that we discovered in the course of doing this project is that a lot of the messaging that was reaching refugee groups was happening through WhatsApp. So pieces of the sheet you could actually take a snapshot of the piece of the sheet and send it through WhatsApp to a much wider group. So that was happening. What else was happening was they were getting circulated, and so the sheets would show up in different places around the world. And they were being added to databases for public health resources, and they were being widely shared. And then the actual information design itself and the graphic treatment was also being copied, which is, really an amazing outcome for what was a very rapid project. So just to kind of give you some sort of key features, they were sort of black and white printable, so no color ink, plain supportive language, reassuring tone, very consistent infographic style, multilingual. So we had 43 different languages. We crowdsourced the translation, open access, downloadable, customizable for local adaptation. And then you can use them for printouts, posters, and digital media. So we made them possible that there really wasn't a lot of editing needed. You really just had to be able to cut and paste or take a screenshot in order to use the tool for something else. So some of the results from this particular piece of work, this is just a snapshot of, we tried to track downloads. It wasn't super easy to do. I wasn't super committed to it at the time, was pretty busy kind of managing the sheets. But we were able to kind of take some snapshots of the downloads. So I think in a one month span, we had downloads from United States, Australia, France, China, Vietnam, and a bunch of other countries. Like this is just a tiny small snapshot of where it was being used and downloaded. We started to get people sending us pictures of the sheets. Hey, I saw your sheet. So one of those situations with this was with the Scotiabank max vaccination sites, and some of the max vaccination sites that were popping up around the most sort of vulnerable areas of the city where there was a lot of transmission happening. And because we provided so many different languages, people could really tailor what they were showing to people based on the community needs and the local context, which was also another really nice outcome. A lot of groups started to, as I mentioned, put the tools into digital databases that were used to spread among people who kind of do this work internationally. So Access Alliance is a really big partner in this work. They are a multicultural health group, and they provide translation services and access to a range of different health resources, and one of them is through something called RioMix, and RioMix is a database of resources that's kind of identified globally, actually, although it's only intended for Ontario. It gets used by a lot of different groups, and our stuff was put on their database, and then it became available to many more people. And it was actually because it was on the database, it gave the tools a kind of legitimacy that is needed in the public health space. So you really want to know that your guidance and evidence is coming from a legitimate source. And so having these endorsements and having these places where we could point to where our tool was really sort of helpful for people to be able to make the argument to actually use the tools in practice. So what that looks like is, a family physician's office somewhere in Haldimand, and they are having an outbreak among their agricultural workers who are usually undocumented migrants, and they need something that is in Mexican Spanish, and they need something quick and something that's easily deployable, and they can go to RioMix, see what we have, and then pick out the language and use it. But in order to make that argument, they need to be able to get it from a legitimate source. Another kind of indicator, and I would say another kind of aspect of the open innovation piece of the project, was we started to get sort of bespoke requests. So this looked like additional sheets, it looked like specific languages, and we got a number of those over the course of the project. People would just find us, send us the request. We'd invite them to be involved, and then they'd become part of the team of people that really sort of worked on this. So I'm happy to answer questions, by the way, about any of the projects separately or kind of the theme overall if you're curious about different aspects of it. So this kind of took a life of its own. It's still available. The principles are now being shared with other groups that do similar work, but in different areas. And I'm now going to talk about the last project. So this one, I think I presented last time I met with you guys. We were doing the work at the community level. We were doing co-design workshops. We were engaging with a whole range of different stakeholders on first aid for addressing the overdose crisis. Thank you. And so for this one, I'm not going to spend too much time on the actual process because I covered that last time. But for those of you who weren't at that presentation, this was a collaboration between a number of partners, primarily St. Mike's, but also Toronto Public Health, The Works, and Dalalana School of Public Health at U of T, and various people at the Li Ka-shing Institute as well. This has been a really big project. So it's been a number of years now that we've been working on this. And it was also part of a clinical trial. So our piece of it was actually all co-design based work. So engaging multiple stakeholders in how we bring first aid for overdose to a wider audience. So beyond the kind of what was happening at the time and is still happening now, which is very kind of specific not-for-profit groups and public health groups who are working directly with people who use opiates and responding within those communities, but to try to actually bring it to a much bigger audience and to reach people who may be at risk of overdose or the people around them. So family and friends, co-workers, colleagues, people who are in the environment around people who might be using opiates and who might be at risk of overdose. So the scope was actually quite big. And we wanted to create a tool that would work across a couple of different environments. So we ended up creating a tool that could be used in a lot of different environments. This is the outcome, one piece of the outcome. So there's two kind of outcomes. The first is the actual kit itself. So this is a rendering of the actual kit. It's made of a waterproof substrate. It can be assembled by anybody. So it flat packs. So you can print in a production, like a package, you can get a packaging company to print these en masse. They cost a lot less than the existing packaging per unit. And they were designed with people who use opiates, together with our team and public health people. So it consists of 2 nasal sprays within a waterproof sort of jacket. And when you open the jacket, the instructions actually follow the same sequence as you would have to respond in an overdose. So it follows the overdose protocol in a visual, non-language reliant way. So again, using some of those principles we had in the other project. And then, so that's what you can see when you open it up. This is an earlier prototype where you have your shake and shout, call 911, get to the ground, insert the nasal spray and press, do chest compressions, and then repeat that cycle. So very simple protocol for the first aid response. And then our graphics are optimized for easy printing, like cheaper printing. So we've kind of got the packaging design so that it's going to be super low cost, and that it's also going to be supportive in the moment of having to respond. So, okay, you might have gotten training, but maybe that was a while ago, or in the moment you're kind of a little bit stressed, probably. So having a visual sequencing that again is kind of supportive and simple will help people actually respond in the moment. And then we twin that with a ultra brief shareable animation. So there's an ultra brief 2-minute animation that can be used as it's on its own as a training tool. It can be shared, it can be reviewed, and it echoes the same visual treatment so the aesthetics and the visual choices that we made and the graphic design match across those 2 different things. So there's nothing actually kind of, in the back end interesting. There's no AI happening. There's no but it's fit for purpose. So you can take this and you can send it to a friend. You can follow the QR code or share the QR code. You can take a picture of it and send a sort of sampling of it if you want to other people. This is the kind of outcome of the design work. So this is a rendering of the many different varieties of ways in which you can print this packaging. So we've deliberately made it super easy to brand, again, kind of because we identified the need to be locally adaptable, so customizable in the local context for, say, St. John's Ambulance or a university wellness center. So that you can take the actual digital files. We provide the digital files. They're openly available through Creative Commons. We provide instructions for editing the files and getting the files into production. And then we have 4 different versions of the ultra brief training. We hope to expand this, but this is what we had funding for in the current moment. And then it's all available through, as I mentioned, a Creative Commons licensing. So you can download and print the actual packaging and then assemble these yourself. So the other piece of this is the kind of actually the process of assembling. So the idea is that you would get maybe a pack of 10 of these or maybe more. And you might have a small community group. Maybe it's a religious group or a not-for-profit or a community interest group. Think of Belleville more recently. They're a really good example of a small city center that has had a huge uptick in overdoses recently, very under-resourced. And you really want to bring the community of Belleville along with you in response to the crisis, and sort of destigmatize the entire process of response. And so part of that is the kits. So we provide this kit that is customizable and you can assemble in a church basement or a community hall or in a school. And then through that process of assembling, you can destigmatize the issue, and you can also educate people in how to respond in a way that's very accessible and shareable. So there's the digital landscape of the work, and then there's the community sort of aspect of the work. So I have to give you some theory. I have to kind of give you a little bit of like, where does this sit in the HCI landscape? Well, I think to do that, we kind of have to reach backwards a little bit into some of the ideas that were floating around in the kind of early to mid 2000s, which is a long time ago now, frighteningly long time ago. We were talking about mass customization and open innovation and peer production, crowdsourcing. Some of what I think is characteristic of these projects is that they have elements of these. Elements of crowdsourcing, definitely open innovation in terms of the licensing, very strategic to do that so that we're not, creating any kind of barrier to uptake or adoption. A small amount of sort of social embeddedness in terms of peer production, not necessarily mass customization, but it's not a commercial endeavor, but you could actually look at this and say, okay, what are the actual, technical elements of this that enable mass customization? It's a little bit of a stretch, but it's there. But the other things I think that are worth considering are really actually not coming from HCI. They're coming from sort of management, innovation, science, product innovation, business school types of research work. I kind of look back to lead user theory. This is von Hippel. This is a long time ago. Interestingly, it really didn't kind of develop very far. It's sort of the idea of lead users is that, where there's a gap in the marketplace, where people have a really high level of need and a continued experience of the same issue over and over again, if there's nothing to solve that challenge, they will start to iterate, or some will start to iterate and create a solution for themselves. You can certainly see that in the overdose crisis. And I think that, what we've done with the work is to take some of the principles of lead user innovation and sort of work with the community to enhance what they've done already and the learnings that they have around how to do overdose response and the issues of stigma, and take that to the kind of the next level of spread and adoption with the new tool. I think looking at open innovation, certainly there are pieces to what we've done that is open innovation definitely. How we could develop that further would be interesting to do. We'd love to be able to track the tool use. Downloads is one thing, but actually tracking how it's being used and how it's spreading is a completely different endeavor, but totally possible technically. And then really, I think we need to look at frugal innovation as a concept that really works in a lot of these concepts, a lot of these contexts. So, we in most of these projects, there really is no commercial marketplace for the work. There's very little available monies across the healthcare system to address what are pretty key challenges. So, being able to communicate among different providers to make sure somebody has continuity of care, it's pretty basic. And in a lot of the contexts, we're really not looking at, we're looking at a lot of competing interests for money and resources. So I think the frugal innovation work, I think this paper actually is particularly useful, helps to kind of contextualize the work in a wider trend of innovation and digital tool development, but also non-digital tool development. So thank you very much for listening. I hope that sparks some interesting conversation. And you can reach me here if you can't stay for longer for conversations, but I'm really looking forward to your feedback and any questions you have, whether it's related to low-tech innovation or, the actual projects themselves or the techniques we've used. I'm happy to entertain any kind of questions.